Pre-hospital pain management for children. Educational Module 1. Pain management in children in general is inadequate, and one of the missions as EMS providers is to decrease suffering and provide comfort. In this educational module, you will learn the key elements of pain physiology, pain assessment, and pain management interventions for injured children experiencing pain. This training module is the first of 2 modules funded by the Maternal and Child Health Bureau and Emergency Medical Services for Children. Objectives. After completing this first module, you will be able to 1. Define pain and its purpose. 2. Discuss the effects of untreated pain. 3. Identify common barriers to pain management. 4. Choose age-appropriate pain assessment tools. And 5. Understand the various options for effective pain interventions in children. In order to make this module more clinically relevant, we begin by introducing a case you may have experienced in the field. This case will be referenced throughout the module. As you progress through the module, please consider these issues listed on the slides as you relate to this case. And the case is, 12-year-old football player sustained a right lower leg open fracture with 90-degree angulation. Patient is screaming of pain and anger. And consider following issues during the presentation. Question 1. Why is pre-hospital pain management important? Question 2. What is the initial assessment and interventions? Question 3. What is the best method of pain assessment? Question 4. Indications for pain management. Question 5. What determines the need for pain medications? Question 6. What medications should be considered? Question 7. The dose and route of administration of this medication. So let's start by answering what is pain. Per Webster's dictionary, pain is defined as a negative experience such as punishment or suffering. In physiological terms, pain can be described as noxious stimuli received by naked nerve endings characterized by physical discomfort. All of the above definitions is correct. However, it does not account for the emotional aspect of pain. A more complete and easily understood description of pain comes from the International Association for the Society of Pain Subcommittee on Taxonomy, which states, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So why is acute pain important? There are some benefits to acute pain. As the initial pain experience alerts the person, he or she can take actions to ensure survival. An example would be a child being physically bullied by another child. In order to ensure survival, the child can either choose to run or fight. In addition, pain helps to prevent further injury. You can imagine a toddler accidentally touching a hot stove. The painful burning sensation alerts the child to react immediately by pulling the hand away and avoid further injury. Internally, as the pain slowly subsides, pain response within the tissue triggers wound healing by mobilizing specialized blood components to enhance clotting and to start the healing process. The last beneficial component of acute pain is the cognitive awareness to decrease pain by avoiding the cause of pain the next time. The prime example is the child not willing to go to the doctor because they associate the doctor with the shot he received the last time. As you can see, acute pain actually does enhance a well-being of a child. But what happens when the pain is prolonged? Does it continue to be beneficial for the patient? Does untreated pain have any harmful effects? Untreated or prolonged pain has pronounced negative effects. In addition to the obvious physical discomfort or suffering, the negative biochemical effects include increase in metabolic rate. If the increased metabolic rate persists, it will eventually exhaust a child's cardiorespiratory reserve. Also, prolonged pain activates and consumes clotting factors at the injured site, leading to overall alteration of the clotting process. It also causes hyperimmune response that may interfere with global bodily immune response. Beyond biochemical alterations, untreated pain causes significant emotional stress or suffering. Main reasons for these stress are anxiety, powerlessness, and loss of control. As the pain continues, children may become more anxious and agitated. Returning to the case, question 1 asks, why is the pre-hospital pain management important? By instituting early pain management, we want to minimize the negative effects of untreated pain as listed in this slide. The behavioral responses to pain, called stress response, trigger complex biochemical and physiological changes. Biochemical changes include the release of many hormones like epinephrine, norepinephrine, steroids, growth hormone, glucagon, and more. These hormones have been used in research to measure stress response in infants undergoing painful experiences. Physiologic changes include elevations in heart rate, respiratory rate, and blood pressure. While these changes are usually seen with stress due to pain, but these changes cannot be used to gauge the pain severity. Finally, the behavioral responses such as facial grimacing, withdrawal or kicking, and crying is more often consistently seen in younger children, and these behavioral responses are one of the methods used to assess pain in these children. We have learned that acute pain is beneficial to the patient and prolonged pain has negative effects. What do the studies say about the benefits of pain relief? There is a handful of evidence that documents significant clinical benefits in infants and children when the stress response is reduced with the use of opioid analgesics such as morphine or fentanyl. In a landmark study, Dr. Arnaud found that providing a high dose of fentanyl to neonates during surgery substantially decreased their stress hormone levels during and after surgery. In addition, they also found the morbidity and mortality was significantly reduced in these patients. This demonstrates the benefits to surgical patients. What are the indications that pre-hospital pain management is beneficial? Beyond morbidity and mortality, inadequate pain management can alter the response to subsequent painful experience in children. In a study by Taddeo, on neonates undergoing circumcisions, facial grimacing and crying of infants who received topical anesthetic compared to those who did not, they found that the stress response at 4 to 6 months vaccinations was significantly lower in patients who received anesthesia during circumcision. They conclude that if pain is not appropriately managed during the neonatal period, it could result in significantly higher pain response even 4 to 6 months later. In addition to that study, the consequence to inadequate pain management during painful procedures in older children was studied. In this study, one of the groups received fentanyl Oralette in a lollipop form, and the other group received placebo lollipop without any fentanyl for spinal taps. Those who received fentanyl Oralette significantly had lower pain scores. More importantly, during the subsequent spinal taps, the patients who received fentanyl lollipop continued to report lower pain scores. The conclusion was that children whose pain is not adequately treated during initial painful procedure will experience higher pain and stress response during subsequent procedures. Returning to the reference case, the information provided in this study will explain why early pain management is important. Patients may exhibit less stress response during the subsequent painful event. With the knowledge that prolonged pain should be minimized, we need to address specific benefits that pre-hospital pain management may bring. Pre-hospital pain management may decrease the pain and suffering of the patients, and also, pain management can provide comfort during transport. Many parents have complained that patients with fractures, although stabilized and splinted, experience a significant amount of pain while the rig is moving or hitting the bumps. This can be minimized by providing appropriate pain management. Pre-hospital pain management expedites the evaluation and interventions in the emergency department. For example, if a patient with a fracture is in significant amount of untreated pain, The physicians in the emergency department will provide the patient with pain medications prior to obtaining any x-rays of the site of injury to prepare the patient for the manipulations required while taking the x-rays. By now it is obvious that improvement of pain management is necessary. However, changes are not happening as fast as expected. Variety of perceptions about pain among the patients and their guardians and the medical professions to complicate the pediatric pain management and create significant barriers in implementing appropriate pain management improvements. These barriers include incorrect assumptions and attitudes, lack of accurate pain assessment tools, and complexities of pain assessment due to subjective experiences of pain and the fact that children are not able to verbalize pain and their inability to separate pain, fear, and anxiety. And inadequate training is, of course, an underlying contributor of all these barriers. There are many incorrect assumptions and attitudes about pain. Some caregivers inaccurately believe that the amount of pain is relative to the type of severity of injury. Pain is a personal experience which cannot be predicted, described, or judged by anyone other than the person experiencing it. For example, depending upon prior experience and understanding of the event, a child may react to a needle stick as insignificant as simple poke, while another child may think of it as so painful that they have to resist vigorously. There are several incorrect assumptions related specifically to children, among which is that newborns do not feel pain. We have established earlier in this presentation that newborn babies do feel pain and respond better when they have received adequate pain management during procedures. A similar misunderstanding is that small children have no memory of pain. Children do remember that needle hurts. That is why they are fearful of doctors. Subconsciously, their memory of initial painful experience makes them react with greater stress during the subsequent encounters. Opioids are powerful drugs, and they metabolize slightly slower in children younger than 3 months. Experts recommend starting with half the standard dose of opioids in infants younger than 6 months old. For example, 0.05 milligrams per kilo of morphine instead of the standard dose 0.1 milligrams per kilo. Although widely speculated that one dose of narcotic can result in addiction, studies have proven that neither children nor adults become addicted if they receive opioid medications for their pain due to trauma or illness. Actually, studies indicate that kids, although getting repeated dose of opioids, will not become addicted. Pain may be thought of as principle of character building in realm of parental teaching at home. But a painful injury should not be seen as an opportunity to build child's character or in the domains of healthcare provider. So withholding pain medication because the attitude that pain is character building is absolutely inappropriate and should be discouraged. The use of pain medication is a sign of weakness. Appropriate use of pain medication to decrease pain and suffering of children who are in pain is a sign of compassionate, caring, and competent healthcare provider who is a champion for a suffering child. No pain, no gain may be appropriate when speaking of muscle-building regimen or lessons learned while working hard to achieve a goal, but it is not appropriate in a setting of injured child. The determinants of acute pain experience include developmental factors such as age or cognitive abilities, psychosocial, cultural, or religious factors, and prior experience. Pain is whatever the patient says it is, and existing whenever the patient says it does. And self-report is the most accurate measure of pain intensity. Ideal assessment tool that allows the patient to simply and accurately score their pain is the first step to improving pre-hospital pain management. The ideal assessment tool should be easy to carry and used by healthcare providers. Finally, the ideal assessment tools should utilize consistent measurement units, enabling the healthcare providers to standardize on just one set of numbers, such as 0 to 10. For the purposes of this training session, we will focus on children between the ages of 4 and 16. For this group of patients, the most appropriate pain assessment tool is revised version of the FACES pain scale pictured here. It is absolutely crucial that this instruction be read to patients before obtaining a pain score. Returning to the reference case, this addresses the question number 3. What is the best method of pain assessment for a 12-year-old young man with fractures? The FACES pain scale, or the revised FACES scale, is the most ideal pain scale that can be used for this patient. There are other commonly used scales. Some of them you may be familiar with. There is a verbal pain scale. You tell the patient to rate the pain from 0 to 10 in whole numbers without showing any scales. This method is used effectively for adolescents and adult population. You may also use visual analog scale, which shows notched or unnotched scale on a horizontal bar, ranging from 0 to 10. This scale is usually used and validated for children 7 years or older, as well as for adults. There are many other pain assessment scales, but you will notice that the measurement units of all scales we have chosen to discuss here are the same. They all begin with 0 and end with 10. Remember, it is important for healthcare providers to standardize their choice of assessment tools, and the tools chosen use consistent measurement units. The same numeric scale for quick recall and interpretation by everyone in the emergency healthcare team.
Pre-hospital pain interventions. There is a priority in pre-hospital pain interventions. First and foremost being the A, B, C, D, and E's. That is airway, breathing, circulation, disability, environment, or exposure. After completing the A, B, C, D, and E's, a pain assessment is obtained to help guide you through the next steps to take. There are two categories of pain intervention, non-pharmacologic and pharmacologic. The next several slides will discuss methods used in both categories, and will address the reference case question number 4, which interventions are indicated for pain. Non-pharmacologic pain interventions are proven to be consistently effective, and those discussed here are universally applied through the use of the acronym RICES. RICES stands for rest, application of ice, compression, elevation, and/or splinting of the injured limb. All of these injury-specific interventions, along with dressings of the wound or positioning of the patient, apply to treating the 12-year-old boy in the reference case as the first measure of intervention. There are other non-pharmacological interventions that would reduce the fear and anxiety of a patient. Talking, distraction, the presence of one or both parents, allowing the patient as much control over the situation as possible, and imagery. Explaining to children 5 and over will remove the fear of the unknown. It is said that the fear of the unknown is much greater than the fear of pain. Telling the truth is very important for some children, especially those older than 5 years of age. Other distraction methods, effective across all age groups, include the use of toys or gadgets, books, or even music. Having the familiar face and voice of a parent present at the scene is particularly soothing and reassuring to a young patient in pain. Children over 3 years of age benefit from patient control techniques. As mentioned earlier, children feel powerless and anxious when they lose self-control. By getting the patient involved in their care, you can give the patient some control over the situation. Something as simple as giving the patient the option to be transported sitting up or lying down, or a choice of whether they like an IV started in their right hand or their left hand, can have a positive effect on their sense of control. Asking the patient to imagine they are in a different, more pleasant situation, referred to as imagery, can also be used with children over age 3. A good example is to tell them to imagine being in an amusement park riding on a roller coaster. Revisiting the reference case, these non-pharmacologic interventions are absolutely necessary for this 12-year-old who has sustained an open fracture. As you are talking to the patient, you may be able to distract him back to the football game with imagery. Having the parents available in the rig, explaining your actions, telling the truth about what he is to expect, and allowing the patient to participate in his care will significantly reduce his stress due to fear and anxiety. So what happens when non-pharmacologic pain interventions are not enough and the patient is continuing to complain of pain? A reassessment of pain is now necessary to guide decision-making regarding the need for pharmacologic intervention. If the patient continues to report a pain score of 4 or greater, morphine should be utilized for pain relief. Question 6 of the reference case asks, what medication should be considered? Morphine is the most available drug on emergency vehicles, and therefore the most commonly utilized for pre-hospital care providers. Thus, morphine sulfate should be given. If your EMS system has other short-acting opiates available, they could also be given, based on your system's guidelines. Morphine sulfate is the gold standard pain medication, and is available on most EMS systems. It is important to understand the full pharmacodynamics and properties of morphine to be able to use this medication properly. The onset of action of IV morphine is usually within 5 minutes, but its peak effect is not reached until 15 to 20 minutes after administration. The duration of clinical effects, that is, the pain relief, can last 4 to 5 hours. Of course, the duration of pain relief does vary from patient to patient. Therefore, it may be possible for the patient to experience an increase in pain within only 30 minutes or an hour after morphine has been administered. There are occasional side effects encountered from morphine worth mentioning. Nausea and vomiting, while rare, do require quick reaction and supportive care from the emergency caregiver. Another infrequent side effect is an allergic reaction. It is characterized by local itching or hives. This reaction is a result of histamine release and may be limited to the IV site, or it may be generalized. It can be treated with Benadryl. Hypotension may occur due to the vasodilatation properties of morphine. Thus, morphine should be used cautiously in patients with shock or hypotension. The most feared side effect from morphine is respiratory depression, which is very rare with standard dosing of morphine at 0.1 milligrams per kilogram. Should this side effect occur, the patient should receive Narcan, supplemental oxygen, and close monitoring. At higher doses, sedation may occur, in addition to pain relief, possibly affecting the patient's mental status. However, as with respiratory depression, this side effect does not usually occur at the standard dose of 0.1 milligram per kilogram. Morphine is contraindicated in patients with known allergies to morphine, presence of any cardiovascular instability such as hypotension or shock. If the patient is already experiencing respiratory depression or poor respiratory effort, morphine must be given with extreme caution. The ideal route for administering morphine is IV. However, IM and sub-Q are acceptable in cases where IV administration has failed or an IV seems unachievable. The dose of morphine for children is 0.1 milligrams per kilogram with a maximum dose of 4 milligrams per dose. However, for children less than 6 months of age, half the normal dose, or 0.05 milligrams per kilogram, should be given. If subsequent doses are needed, the pre-hospital provider should contact medical control for additional doses.
What happens after a patient arrives in the emergency department? For example, a patient with a fracture. If pain management has not been addressed prior to arriving at the emergency department, the patient will be initially evaluated by a nurse and a physician, and then once the patient's injuries and the pain severity have been assessed, an IV will be started and pain medication will be given. Then the X-ray of the extremity will be performed. The reason pain medication is given before X-ray is that manipulation of the extremities involved, which can be extremely painful. If pain has been adequately addressed prior to arrival at the emergency department, the steps prior to and including IV starts could be totally eliminated, expediting the patient's care by getting the X-ray immediately after arrival to the emergency department. This helps us address question number 1 of the reference case again. Why is pre-hospital pain management important? Answer to this question includes pre-hospital pain management is especially important when emergency department care can be expedited and can reduce the pain and suffering of patients who are waiting to be seen. To summarize what you have learned in this module, pre-hospital pain management is very important. Untreated or prolonged pain may limit optimal outcome in patients. Pain management starts with pain assessment using appropriate pain assessment tools. Initial comfort intervention should be provided to all patients. When necessary, appropriate administration of pain medication can decrease suffering and expedite care in the emergency department.